Good evening.
Good evening.
Good evening, presenters and participants. We are ready to start the meeting now. And I'll start by welcoming all the participants. You see, we have over 50 participants who are logged in, and we have actually 60, and we are anticipating that there'll be more who will be logging in as we proceed. So welcome those who are already with us, and also welcome those who are going to join us. And we look forward to a very participatory and interactive, webinar this evening. This is a webinar that has been arranged by the Karen Hospital in conjunction with the Alliance Old Girls Association, a subgroup called Health Living. And we are really very excited about being this being the very first webinar, for this group that is very interested in health living in all its aspects. And today we'll be concentrating on cardiovascular health. I also want to welcome the presenters, and I will go straight to the point of introducing the presenters this evening. Our presenters are, and at the same time as I introduce our presenters, let me also recognize Dr. Priska Mutua, an OGA, Old Girls Association, very active member, who will be giving the vote of thanks, at the end. Who are our presenters this evening? Thank you, Priska. we are meeting online. Thank you. I'm sure it is not very cold there in UK. Our presenters today this evening is one, Dr. Dan Gikonyo. Dr. Dan Gikonyo, maybe you put up your hand. People might see you're muted. Thank you. He's going to present heart diseases and COVID-19, and today. And Dr. Dan Gikonyo is a founder, director, and chief cardiologist at the Karen Hospital, a graduate of the University of Nairobi Medical School, both in undergraduate and in internal medicine postgraduate, and also a cardiologist trained at the University of Minnesota in USA. He's a fellow of the American College of Cardiology, and he has over 46 years of experience as a doctor. We shall welcome all of them together just in the interest of time. The next one is Dr. Ponoth Prem. Dr. Prem, thank you very much.
Yes.
Presenting. Thank you so much. Dr. Prem will be, Prem is short for a very long name, so he'll be presenting surgical management of heart diseases. And Dr. Prem is a cardiothoracic surgeon at the Karen Hospital, Nairobi, and he has quite a list of qualifications, including an MS, FIACS, a fellow of the College of Physicians, FICA, amongst many. He has over 25 years of experience in a cardiovascular scene, and he will be taking us through surgical management, of heart diseases. Our third presenter, for this evening will be Dr. Anthony Gikonyo, who is an interventional cardiologist at the Karen Hospital, Nairobi. He's a director. He's a graduate of Howard Medical School in the US, MRCP of UK, an interventional cardiologist from the University of Wits in South Africa, with 19 years of experience, in the field of medicine. We also have our very own old girl of the Alliance Girls High School, Dr. Shango. Dr. Shango, if you could put your video on, people might be able to see you. Thank you. So Dr. Shango is our next Alliance Girls High School, and she's a physician at the Karen Hospital, a graduate of the University of Nairobi for both undergraduate and postgraduate in internal medicine. She has 13 years of experience in the medical field and has specialized in varicose veins. And the last speaker will be Dr. Stephen Omondi, who is a physician cardiology fellow at the Karen Hospital with undergraduate and postgraduate training at the University of Nairobi. He has 10 years of working experience. So participants, join me in welcoming these our six. Okay, I don't need much introduction. I'm going to be also a presenter, and I am a pediatric cardiologist, graduate of University of Nairobi, an ex-Alliance Girls High School, and a pediatric cardiologist from the University of Minnesota, and I have over 46 years of experience as a doctor. So, participants, please join me in welcoming the presenters who will take us through today's presentation. And I will start by requesting Dr. Dan Gikonyo to just give us a small introduction of the Karen Hospital. So if you could be assisted to share the screen, Dr. Dan Gikonyo. We have over 70 participants already, and we are ready. Dr. Gikonyo, welcome.
Thank you very much for allowing us to be part of this informative discussion on cardiovascular disease. I am talking from the Karen Hospital, and to all our participants, I feel very privileged to be part of this discussion. The Karen Hospital is now a reasonably well-established institution since the year 2006, when we opened our doors, when the hospital was formally opened by none other than the third president of this country, Honorable Mwai Kibaki. Since then, the Karen Hospital has grown not only as an institution of medical care as a hospital, but we have been able to expand to other areas where we have introduced a medical training school, the Karen Hospital Medical Training College, which trains, amongst others, Kenya registered nurses, clinical officers programs in cardiovascular disease, and we are proposing to be introducing an ICU program course for nurses. The Karen Hospital also has established itself in other areas outside Nairobi, where we have by now 9 other satellites, which are outpatient facilities that we run in various places in Nakuru, in the CBD here in Nairobi, in Thika, Rongai, Karatina, Nyeri, Meru, and Naivasha. In addition, we have our corporate responsibility arm, the Heart Foundation, which many of us by now know, which is an organization that we use to assist poor children access cardiac surgery that they would not otherwise be able to afford in view of large costs. So the Karen Hospital is a health system that incorporates the hospitals, the satellites, the Karen Hospital Medical Training College, and the Heart to Heart Foundation. Our topic for today is cardiovascular health. And in the current day and age, we cannot talk about cardiovascular disease without mentioning the latest monster in this field, COVID-19. For a long time, the developing countries have been fighting with infections like HIV, TB, and malaria. And when we thought we were just winning that battle, a new infection has landed on us, the COVID-19. This is a major hit on the developing world because, on the other hand, we are now being invaded by non-communicable diseases, diabetes, high blood pressure causing heart attacks, strokes, and cancer. So we are in a crisis. The worst crisis is the one that started in this country in March, in the world last year, but one in September in China, the COVID-19 virus that has spread and now wreaking havoc all over the world. We are lucky that in Kenya and in Africa in general, in rather the tropical Africa, we have been spared the intensity of this scourge. In Kenya, as you remember now, as per today, we have had over about 99,000 cases and 1,700 deaths so far. The 1,700 deaths are many. There are things to worry about in this country, but remember that other countries in the world have fared much worse, and the good Lord has been kind to us that we have had such low fatalities in this disease. COVID-19 interacts very closely with cardiovascular disease. For those of us in the audience who have an understanding of human body science, you know that most of the body cells have what is called receptors. That's how they communicate to the rest of the body parameters. It's like a receptor is like a keyhole in a door, such that when somebody is to receive a message, if you are to give a receptor a message, it passes through that receptor to the inside of the cell. There is a receptor on all our body cells called the angiotensin converting enzyme, receptor 2, which is where this virus attaches itself as it comes to attack the rest of the body. It's very important that you remember this is a receptor disease, such that if you are lucky and you have less receptors, then you get less severe disease. The more receptors you have, the more severe disease you shall get. And maybe the reason we are getting less severity of the disease in Africa is maybe that our populations may be having less of these angiotensin receptors on our body cells that are on every cell, but much more prevalent in the lungs and the cardiovascular system. When this COVID-19 attacks or attaches itself to the receptor and enters the body cells, usually the main point of entrance is the respiratory system. So as you breathe in these viruses and they go into the lungs and the airways, they finally end up entering into the cell itself and multiplying using our own DNA and RNA system. Once they start multiplying in the lung or in the respiratory system, they are not restricted in that system. And they spread to the rest of the body, much worse, affecting the cardiovascular system. That is why we are talking about COVID now, because COVID and cardiovascular system are very closely interrelated. When the COVID virus enters the cells, the body mounts a response. We call it an inflammatory response, which initially is supposed to be protective, but it becomes an inflammatory system all over the body. And most of the complications we are seeing in COVID are related to this systemic inflammatory response that occurs in the cardiovascular system. It is this systemic inflammatory response that causes the rise in temperature in our bodies. Once you get COVID, increases the heart rate, damages the lungs, and therefore increases the respiratory rate as we try to compensate. You get an increase in white cell count but much more damaging. It causes thrombotic events in the body. It causes a cascade of blood clotting all over the cardiovascular band. And wherever it causes this blood clotting, it damages tissue, such that a disease that initially is in the respiratory system ends up being a cardiovascular system, damaging the heart, the brain, the kidneys, and all organs in the body, because we all the organs share a cardiovascular system through the blood vessels. So I can give an example of what happens in this COVID inflammatory response to a matchstick. You can imagine the virus as a matchstick. You strike a matchstick and you get a very small flame from the matchstick. But if that flame were now to spread to other areas, it can cause a huge conflagration. A small strike from matchstick can cause a huge fire in a forest or in other areas and can destroy buildings, trees, and other facilities. That is what the COVID virus does. It starts as a small thing, a small infection in the lungs, and then spreads all over the cardiovascular system, causing a huge conflagration called inflammation that damages tissues. And that's the one that leads to high mortality. Not everybody who gets COVID dies, but that's because there are different risk factors for this disease. And the reason we are discussing about it is because cardiovascular disease is a major risk factor for COVID mortality and fatality. The biggest risk factors when one has COVID are two that you can do nothing about, or rather one that you can do nothing about, which is age. For those of us who are the age of 60, the risk of having serious complications from COVID rises. Another factor, but this is something you can do about, is excess body weight. It has been observed that people who are overweight get more complications from COVID. Overweight is a risk factor not only for COVID, but for cardiovascular disease. People who are overweight are more likely to have the other risk factors that we see as risk factors for COVID, which include the high blood pressure, hypertension, diabetes, poor sugar control, chronic kidney disease and heart disease, of course, cancer, HIV, and other severe chronic infections like tuberculosis. All those are major risk factors for COVID complications. I show this slide here to show you the risk of dying from COVID depending on what your underlying risk is. And I want you just to focus on this last column here, the cardiovascular disease. If one has cardiovascular disease, the risk of dying from COVID goes up to 10.5%, as opposed to other conditions where you don't have the cardiovascular disease. In those who have no pre-existing conditions, who don't have cancer, hypertension, respiratory disease, or diabetes, the risk of dying from COVID is less than 1%. That's why the risk of dying from COVID in children is much less than in adults, because they have less and less of the pre-existing conditions. But don't panic, because COVID will come and go, because man was given dominion over all things by his creator. If you read Genesis 1:26, it says, God said, let us make man in our own image, after our own likeness, and let man have the dominion over the fish of the sea and the fowl of the air, and over the cattle, and over all the earth, and over every creature that creepeth upon the earth. Every creature that creepeth upon the earth includes the viruses, and therefore we shall have dominion over them, and we shall overcome. Just like we overcame the flu of 1918, the Spanish flu, that killed over 50 million people in the world. And those days they couldn't count very well, so most likely there were more than that. So far today, COVID has only claimed less than 2.1 million people in the world, so we are still lucky. But the flu of 1918 came and went. Smallpox came and went, as you can see on this graph, and that's why I say even COVID itself will go away with all our small interventions that we are doing. HIV came in the 90s, and gradually the incidence and prevalence has also faded, although it still remains with us as a major health risk in our communities. Cardiovascular disease is a disease that we can, to a large extent, prevent in our own cells because it's not a disease that occurs by accident. Cardiovascular disease is a lifestyle disease. It's a disease that you can modify by modifying our lifestyle. We can reduce the number of heart attacks that we get. We can reduce the severity of diabetes and high blood pressure, depending on our lifestyle. So far, cardiovascular disease remains the major cause of death in the world, both in the developed and developing world. Of all the global burden of disease, 85% in the lower and middle income groups is from cardiovascular disease, or rather the non-communicable diseases. And when we talk about cardiovascular disease, we focus mainly on the heart. And we focus mainly on two vessels that feed the heart, called the coronary arteries. Tiny little vessels, about 2 to 3 millimeters in diameter, the right and the left coronary artery. It is when these get blocked or narrowed that you get a heart attack that can be fatal in 30% of people before they reach hospital. Coronary artery disease is a progressive disease, starts in our youth and gradually progresses by laying down of fibrin and cholesterol on the inner surface of the blood vessels, clogging them, not selectively in the heart, but clogging our whole cardiovascular tree in the heart, in the kidneys, in the brain, in the peripheries, in the arms and legs, causing cardiovascular obstructive or atherosclerotic disease, which is progressive, as you can see, by decades. In the first decade, the vessels are clean. By the time second decade, they are starting to have these blockages. By the time you get to the 7th decade, those of us who are 70 and above, there's significant blockage due to a process we call atherosclerosis. Develops over a period of time, but presents with things like chest pain, which we have heard about called angina, shortness of breath, and eventually can present acutely as a heart attack when a blood vessel becomes blocked. My message is, should you have chest pain that comes in your chest that makes you feel breathless and you feel like you're going to pass out or you start sweating, please make your way to the hospital. There are the 6 golden hours we call. If you can get to hospital in the first hour, or the better. If you can't, within 6 hours, we can abort a heart attack. Before you leave home, take an aspirin. The risk factors are well known because we have all been told about them. The one that we can do something about, called the modifiable ones, and the ones that we can do nothing about, which we call non-modifiable. But it's in our hands to prevent progression of cardiovascular disease by lifestyle. Avoid getting overweight. If you want to know whether you are overweight, check your waist circumference for men. If you are over 102 centimeters around the umbilicus, you are already overweight. For women, if you are more than 88 centimeters around the umbilicus, you are overweight, and you need to reduce weight to reduce the risk factors of cardiovascular disease. Monitor your blood pressure regularly. It has been shown that the mean systolic blood pressure in our country, in Kenya, is gradually increasing over time as we gain weight, become more sedentary, and eat bad diets. The same with diabetes. It's been shown that diabetes is gradually increasing in our populations. The mean fasting blood sugar keeps on increasing as monitored by WHO. And this is something, again, that we can modify and avoid. Diabetes continues to be a major risk factor for cardiovascular disease. This is well known, and diabetes in adults is to a very large extent a very preventable disease because it's lifestyle. We cannot talk about respiratory disease with cardiovascular disease without talking about cigarette smoking. is a major factor in the risk factors that promote cardiovascular disease and atherosclerosis, heart attacks, and fatalities. Body weight is something you can take care of because, again, it's exercise and diet. Please know your body mass index to make sure it remains in the health area. And you can do this by dieting and exercising. The mean body mass index, again, in our country is gradually increasing. More and more people are more obese than they were 20, 30 years ago because of bad diet. So please attend a wellness and preventive medicine clinic, get your annual checkups, and I can promise you, if that is done, you will remain well. Thank you very, very much.
Thank you very much, Dr. Dan Gikonyo, for that presentation. That has shed a lot of light, and there are quite good comments that are on the chat about the information that you have been able to give to the team. Our next presenter will be Dr. Onoth Prem.
Yes, Dr. Betty.
Yes, please welcome, and
thank you.
We are ready.
Dr. Betty, I don't have any slide presentation because me and AK just came out of the theater after an emergency, just half an hour back, but I'll talk. It's all in my head.
That's fine.
So it's a pleasure to talk on this forum. It's greetings from my side to all the participants. Let me introduce myself. I'm an Indian by origin, and I've been working in Karen Hospital for the last 3.5 years, I think. Over the period of time, I would say that we have made a lot of progress. We have done approximately 500 open heart surgeries during this period, which I believe is a big number for the whole of East Africa, not only East Africa, not only Kenya, but the whole of East Africa. And we are pushing our boundaries as the day goes. We have done from 3 years. The youngest patient I have done surgery is 3 years, and the oldest patient is 93 years. So it's a big spectrum, and basically we do all that type of heart surgeries, I'm proud to say, except for very small babies, maybe less than 10 kilograms, because for that we need a little more of specialized equipment and team members, which we are in the days to come or in the years to come will be equipped. But at this stage, anything more than 10 years of age, we have done. The heaviest patient we have done is 130 kilograms, a lady, and she went home in 1 week's time. So that's a spectrum we have, and we do everything. Not only the heart surgery, but also the lung surgery, vascular surgeries. You know what I mean to say, vascular surgeries, surgery of blood vessels. So it gives me great pleasure because after I joined here, we started doing new methods of surgery. As you know, for example, it has been known or it has been believed that the African population is immune to coronary artery disease. But when we started probing more and more, we found that we are only scratching the surface of the iceberg. You know, there is a big community, maybe because of the change, as Dr. Dan Gikonyo told, change of food habits, lack of exercise, maybe change of, work environment, more stress, maybe consuming more alcohol, cigarette, smoking, and so on and so forth, hypertension, diabetes, all sort of things. Probably the curse of the modern era has affected the Kenyan people as well. So we find that this heart problem is the coronary artery disease or heart attack has become increased day by day, and we have done up to date for the last 3 years about 76 bypass surgeries here, which I believe is a big number, because in considering to some Asian countries, of course, considering to India, it is less, but it is catching up. And I was also happy to say that most of the cases, probably 98 to 99% of the cases, I do on beating heart surgery. In beating heart surgery, unlike the usual routine heart surgery. We don't use any fancy gadgets. We don't use any heart lung machine. We don't stop the heart. It's just like a general surgery. We do the surgery on a heart which is beating. If you want to give an example, it's like repairing the car when the car is running. Usually, traditionally, heart surgery is done when the heart is stopped. But this surgery we do when the heart is beating, patient is okay without any fancy equipment. We do the surgery. The reason we do it is because the consumption of the blood is less, the anesthesia time is less, patient goes home in 5 days time, and economically more acceptable to the patient because we don't use any fancy things. Only catch is that the surgeon has to be trained to do these type of beating heart surgeries. So we are happy to push that boundary, beating heart surgery, which gives better results to a good number of patients, especially more so with patients, heart patients, as you know, with kidney problem, poor heart, patients who had heart attack, whose heart function has come down considerably. So all these patients, they do benefit from beating heart surgery because if you put the patient on pump, it increases the complexity of the surgery. For example, when you take the blood from the patient to a machine and then bring it back, it triggers inflammatory reaction. Sometimes, it can affect other organs. Sometimes it can cause embolism, which can lead to stroke, and so on and so forth. So we try to avoid all these avoidable risk factors, so that our idea is to send the patient home in a good condition early enough, and so that he becomes a good citizen, and he can look after his family. So that is one thing we do in Karen. And then we are trying to innovate ourselves. For example, in aneurysm, as you know, aneurysm is a disease in which the aorta, the main blood vessels, by distance like a balloon. And those are the surgeries most of the cardiac surgeons dread about, because it's a major surgery, needs about 15-20 units of blood. Patient is in the ICU for 2-3 weeks, goes home in few months time, so, and has a very high risk, about 50%. So all those things are there. So now we are trying to catch up with the other western part of the world like Europe and America, whereby we try to do what is known as endovascular stenting. This is a surgery which is done, which is minimally invasive, whereby we make a small cut in the groin and we put a stent through the artery into this aneurysm. Thereby the patient goes home in 3 days, 2 to 3 days time, short stay, and gets back to his normal life without much problem. Even though it is slightly, I would say it's slightly costlier than the usual surgery, but many people prefer it because it's less invasive, no need of blood transfusion, no need of, in fact, anesthesia is very short time. Sometimes even you can do it under local anesthesia. So all sort of benefit is there. So I think that the popularity is catching up in spite of the fact that it's slightly costly, but I'm sure in the days to come, the price will come down, because the more we use these type of gadgets and instruments and consumables, the company tend to bring down the price. So that is another thing. So then we do valve surgeries. As you know, my practice, about 60 to 70% of my surgery in this part of the world is valve surgery. It can be valve repairs, it can be valve replacement. Excuse me. It can be single valve, double valve, sometimes 3 valves. The reason I would say is that probably because the predominance of the rheumatic heart disease in this part of the world, because of the streptococcal infection the person must have had when they were a child. So this is something which we do on a regular basis, and we have got very good results after it. So sometimes when the valves are badly damaged, then we have to replace it. Of course, there are 2 types of valves available, as you know. One is known as a mechanical valve, which is made from metal. The other one is known as the other one is called the tissue valve, which can be which is made from pig or calf. So we change it. Both the valves have its own plus points and negative points. So we use it as per the need. Usually the mechanical valve is used for young adults, and tissue valves are basically reserved for elderly people or very young people, or sometimes patients in the childbearing age. But there's a catch to it. The longevity of these tissue valves is only 18 to 20 years. So these patients, they have to have another surgery done to replace these valves sometime in their life. So that's why we have to pick and choose what is known as a cafeteria-like choice, whereby the patient comes, we look at all the risk factors, all the pros and cons, and think and advise them what is best for them. And that's the way we go for it. So valve surgery, then I would say about 20% of my practice is surgery for children, heart surgery for children, whereby children come with hole in the heart. Sometimes you get what is known as blue baby syndrome, by which you must have seen when child runs around, it becomes bluish in color. So all those things happen. So so that is correction of hole. So pediatric heart surgery is 20%, and about 10-15% again, I told you, the bypass surgery. So these are the things that we do at Karen Hospital with very good results, and we have established as a major cardiac center for not only for Kenya but also for East Africa. We are getting a reference from the neighboring countries. So we try to push the envelope as much as we can, so that the idea is that the Kenyans should be self-sufficient. They don't have to go for these type of surgeries to India or South Africa or any other place. So that's what we do. So we try to innovate ourselves, try to do the best what we can, so that it will benefit the Kenyans in the long way to go. Thank you very much. Thank you, Dr. Betty. Can you hear me?
Yes, I can hear you. Thank you very much, Prem.
Thank you.
In fact, I had a few of your slides, but never mind.
Please.
Yeah. Thank you very much for that. Overview on what is available in Kenya. Just for confirm that in the cardiac surgery, from mild to complex heart surgeries are going on in Kenya, and the plan is to be self-sufficient and retain Kenyans within Kenya, where they can have their heart surgery, and that's why there is a full-blown cardiac team at the current hospital with cardiologists, both pediatric, adult, and cardiothoracic surgeons, as well as the cardiac anesthetists, as well as ICU nurses who have been trained in the care, both in theater of the patient who require cardiac care, whether in a cath lab or in the theater, or in ICU, or in the ward, or even as an outpatient. Thank you so much, Dr. Prem.
Pleasure.
Yes, participants, we are making good progress, and we will be proceeding to our next presentation. Our next presentation on diseases of the aorta, and this is by Dr. Anthony Gikonyo. So we are ready to listen to the presentation regarding the diseases of the aorta, and this team, most of us have been listening about hypertension in our forum, and maybe we'll be hearing a little bit about the complications of hypertension in the diseases of the aorta. Welcome, Dr. Anthony Gikonyo.
As Dr. Anthony comes in, we shall answer one question that has been asked there about the outcomes of the bypass surgery vis-a-vis operating on a beating heart. The answer is the beating heart outcomes are better than the bypass hearts, because you avoid the trauma of blood cells that you get from the heart-lung machine. And again, too, the recovery time is much less when you have a beating heart and you go through cardiopulmonary bypass. It is true, of course, that not all cases can be done on a beating heart, but the one that can be done on a beating heart, yes, the outcome on a beating heart is better than going through the other cardiopulmonary bypass machine. We can now hand over and move on to discuss aortic valve disease by Dr. Eke Gikonyo. But to mention that aorta is just an extension of the heart, and at the base of the aorta, as it leaves the heart, is where the coronary arteries comes in. And part of the intervention that we do on cardiovascular disease in the aorta, we also do them in the coronary arteries in the heart. So even here at the current hospital, we have the facilities and capabilities, both the infrastructure and the staff support to do acute coronary interventions, such that if somebody comes with a heart attack acutely, we are able to do angioplasty and stenting on arrival. Our hospital runs 24 hours, able to do all these interventions acutely as time demands. And acute intervention early in heart attack is the answer. Both, we can either put a stent, or we can do what is called lytic or thrombolytic therapy, where we actually do break down the clot using medications that can break down clots called thrombolytics. It's unfortunate that this coronary disease has become a major epidemic now. It's something we didn't know in the past. It never existed in Africans for many, many years. But in the last 30, 40 years, it has become now as common as nearly as any other part in the world, as we continue being more westernized and being more sedentary and eating badly. We shall now hand you over to Dr. Anthony Gikonyo, who will tell us more about the disease of the aorta.
Thank you very much for that presentation. So I'll just add on to what Dr. Prem and Dr. DK have started. I'll try and share my screen here and then get to the presentation, which is here, which is this one. So we'll be discussing aortic aneurysms or aortic disease. So an aortic aneurysm is, so the aorta is the blood vessel that joins the heart to the rest of the body. We'll use this picture that we have at the front here. It shows the heart here where the cursor is, and this is the blood vessel that goes to the rest of the body. These red things here are the kidneys, and then these are the blood vessels that divide into two. And this is primarily what our talk will be about, called stents, and which is what Dr. Prem had already talked about earlier. So we'll just discuss the definitions. We'll go through one or two people who presented with this problem, and then we'll talk about the cost implications. So this is, on the right, we have a picture showing what the normal blood vessel, which is the aorta, looks like. And then on the left here, this is what an aneurysm is. An aneurysm is essentially a ballooning out of the blood vessel to the point where it can burst. And on the left here, this is an example of what a stent looks like. And so a stent is a wire mesh with a cloth covering that you place into the blood vessel that allows blood to pass across the aneurysm. And so that ballooned area is no longer used by the body, and the risk of the blood vessel bursting is taken away. So there are two types. There's one called where we do the procedure into the thoracic aorta, and that's just the heart would be here, and this is the blood vessel that goes away. Traditionally, what we would do is do an open surgery where Dr. Prem would go, and it's still done, but now we have an option of putting a stent where you go in, cut the diseased part of the artery out, and then reconnect it with a cloth. These surgeries require a lot of expertise, which is what Dr. Prem has. But now, together with him, we're able to do these other procedures where we just go through the blood vessel in the leg and put the stent through the blood vessel. It means that the person stays in hospital for up to 2 or 3 days, whereas if you do the surgery, somebody stays in hospital for maybe 7 to 10 days. And of course, the recovery is much, much faster. So we've done this many times. We've probably done about 20 to 30 in the last 2 or 3 years as a team with Dr. Prem. This is an 18-year-old boy who came in with severe chest pain. He had a history of hypertension. We did what we call a CT scan, which is a scan using X-rays, where you enter a tube, and it allows us to take more detailed pictures than a regular X-ray. And what you can see here is this is the heart, and this is the vessel here, which has a break in it. And this is what the final picture looked like after we put the stent in. And you can see this wire is protecting the vessel from it leaking or bursting, and which can be catastrophic. Here's a second example of a 60-year-old lady. She was diagnosed with tuberculosis. She had abdominal pain for the past 2 months. We did a CT scan again, and this is what the blood vessel looks like. And you can see this part here this is the normal part. This part is normal, but all this area is abnormal. And this is what, when we finally did at the end of the procedure, this is what it looked like. So the concern was in this red area, there's a chance of the vessel bleeding and leading to death. And once we put the stent in, the likelihood of that occurring is small. The cost implications, of course, this is a life-saving procedure, but it does come at a certain cost. The stents come at about 900,000 shillings. The hospital fee, including doctor's fee, would probably be 700,000. So the total cost is about 1.6 million. The good news is that NHIF, even for general members, caters for up to 500,000. And then the insurance, most people who have insurance, they are able to cover the rest of this from the insurance. But of course, it's a big amount to pay, because it's still 1.1 million if you're having to pay cash. Thank you very much. I hope that was informative, and we're happy to answer any questions.
Good. Thank you very much. Okay. Yeah. Thank you very much, Dr. Dr. Anthony Gikonyo, for that presentation on aortic disease. When I posted the aorta, on our group, everybody was wondering, are we going to be able to remember the biology? But you have made it very, very easy, for the team members, to appreciate the diagram we posted and what you have presented. As we proceed, there were questions that are related to the presentations that have gone by. Is there genetic predisposition of atherosclerosis? And I know that Dr. DK so we could respond to that. Dr. Anthony, and also Dr. Prem, you being the one who does the surgery on the beating heart, the question is very challenging. I think you just made the issue that you have been doing it for many years.
Yeah.
And the only center probably doing the cardiac surgery on a beating heart.
Yes, that's true. So regarding the genetic thing, I can tell you, Dr. Betty, there is genetic preponderance, you can say, in atherosclerosis in the family. Suppose your father, mother, brother, close blood relatives have atherosclerosis, there's a good chance that you can also have it. That's why, I don't know whether they have watched one of the slide what DK has showed. The nidus for the atherosclerosis, nidus for the problem starts well ahead, probably in the first decade of life. And as the days goes by, if the person is not leading a normal life, if he indulge in smoking, drinking, eating, bad eating habit, it starts growing at a very faster rate. So I think genetic preponderance is important. That is why in the Western world, they have started doing what is known as genetic mapping, which we have not started here. In some of the clinics in the United States, like Mayo and Clinic, they have genetic mapping they are doing, especially when there is a strong family history. Incidentally, we have done surgery for a patient whose all the brothers have coronary artery disease, and most of them had either angioplasty or surgery. So those are the family which has got a very strong genetic predisposition. I think genetic mapping is the way to go, but unfortunately in Asia and Africa it has not become very popular. But I am sure in the days to come it will come. But the moral of the story is that if your close family relatives have heart problem, especially heart attack or cholesterol problem, it is better to be on the watch out. It is, especially if you are more than 40, it is better to get a yearly checkup and blood checkup from a qualified doctor.
Thank you very much, Dr. Prem.
Thank you.
Yes, and now we will proceed. The next question about blood clots in the legs will be responded to after we listen to Dr. Shago Irongo, who will do a presentation on varicose veins, a very common problem, especially amongst women, as they age, and also with issues also of weight problems. So, Dr. Irungo, I don't know, I can't see you, but I believe that you're ready to do your presentation. Thank you, Dr. Irungo. Welcome. And we call ourselves GEOs. That's what the girls, because we had a principal, our principal called Mrs. Waidaka, who was very fond of the girls, and her pronunciation of girls was GEOs. So Dr. Irogo is of that generation. I'm from the generation of Miss Bruce. Thank you. Dr. Irongo, you can unmute yourself.
Thank you. I'll start screen sharing. So good evening, ladies or girls. Today I'll be presenting, I'll give a brief presentation about chronic venous disease, which is commonly known as varicose veins. But then it's a wide the disease has a wide spectrum, and I'll share some insights into the disease today. So my outline. I'll talk about the definition of venous insufficiency or chronic venous insufficiency. I'll briefly talk about the lower limb circulation and physiology, and then I'll go into the spectrum of and stages of the venous disease, talk about the risk factors, pathophysiology and the pathology that follows thereafter, evaluation and management.
I can't see the screen, the slide. Can I share?
Can you see now? Okay, just show. I understand you can't see my screen, so I'll ask my colleague to share for me. Yeah.
Dr. Irogo, it says you have started sharing the screen. It's only that we are not seeing.
So I've gone through my outline, the definition. Okay. So let's go to the definition. The definition of chronic venous disease develops when there is a venous return is impaired by valvular incompetence. Three things: valvular incompetence, obstruction, or calf muscle pump failure. If you look at the image on your right of the screen, it depicts an image of two blood vessels. One shows a healthy blood vessel that shows a venous structure. All veins that usually take blood back to the body, back to the heart, and that the blood flow is controlled by a set of valves that ensure there is no backflow of blood back to the lower limbs. But what happens in venous insufficiency, that venous return is impaired either by that valve being incompetent, as depicted on the image on the right, or there's obstruction still of the same valves, or calf muscle pump failure, which are the calf muscle pump that is responsible for the pumping of blood through those vessels. Now, chronic venous disease has different manifestations. In most people, they can be asymptomatic, or you see small bluish bulging veins on the legs. And this manifestation may be very white, may go as from those small bulging veins called the spider veins or reticular veins, to lower limb swelling, which is edema, with skin changes and ulcer formation. Next slide. There is a diagram of the normal lower limb circulation. I've depicted a picture showing arterial flow that is in the red, the vessels depicted in red, and the veins depicted in the picture with blue vessels. So that it shows you that the venous flow, or the venous system, is an intricate system that's interconnected. There are superficial veins, which are interconnected to the deep veins through perforating veins. So this diagram shows here the external iliac vein going down to the femoral and going down to the anterior and posterior tibial vein. That depicts the deep system. The superficial system is mainly is comprised of the greater saphenous vein that runs on the medial side of the leg, and the small saphenous vein that runs at the back of the leg. The picture on the right has focused more on the superficial veins, is what you're going to be discussing today. Venous insufficiency mainly affects the superficial veins of the greater saphenous and the lesser saphenous. That the greater saphenous, as you can see on that diagram, comes on the side of the leg, and the lesser saphenous or the small saphenous runs on the back of the leg. Next slide. When you talk about the calf muscle pump, it's part of the circulation, the venous circulation in the leg. Whenever there is a flow, whenever the muscles contract, the blood flow is caused to flow upwards towards the heart when the valves open, and that helps with the muscle contraction. When the muscle relaxes, the valves prevent backflow back to the legs, ensuring that the blood flow in the legs remain unidirectional towards the heart. Next slide. So what happens in chronic venous disease? As I had said earlier, it is a spectrum, and it may come with a different presentation. And there's a classification system that has been, that helps in classifying this disease according to the severity of the symptoms. So it's that, and this classification runs from C0 to C6, as depicted on that chart. If you start from C1, those are the most common veins that people see, bluish bulging veins on the legs. And that can progress to C2, where you have bigger veins, which are now called varicose veins, which are bigger veins. They're about 3 millimeters in diameter, and they are more visible and may even look like a bag of worms. This disease may progress to C3, where now a person can present with swelling of the lower limb, especially around the ankle and the foot. And these symptoms are usually worse as the day progresses. If this is left untreated, or it progresses on to stage C4, where you have skin changes, where you have hyperpigmentation of your legs, the skin becomes firmer and sometimes harder, and you even see changes due to fibrous deposition in the legs. The last stages of this disease, and now that leads to advanced disease, is C5 and C6, where you have wound formation or ulcer formation, and that will be the last stage of the venous disease. When the ulcer heals, that means it's a healed ulcer, you go back to C5, which is a stage of healed ulcers. So that's the staging system for chronic venous disease. But the most common one we usually see is C1, which is spider veins. Next slide. These are other pictures depicting.
As you can see, if you look, you can see that answers are getting nice.
So these are other pictures depicting still chronic venous disease, but this is more at an advanced stage where you have swelling, skin changes due to deposition of the red cells and hemosiderin, and you even have there at the end of that spectrum where you have where the legs become thinner as you go towards the ankle. They're even called inverted champagne bottle appearance, which would signify a late advanced stage of venous disease. Next slide. This is still another presentation of chronic venous disease. This is called atrophy blanche, where you have polyagonal patches with red dots that also show advanced venous disease. Next slide. So what are the risk factors for one developing varicose veins or venous disease? You have advancing age, especially in people who had a family history, where you find people in the families, the aunties, the sisters, and it tends to affect more females than men. Being overweight or being obese is also a risk factor that results in the valve failure and also poor calf muscle pump function. You have hormone replacement therapy or pregnancy changes that also put you at risk. There are vocations that predispose you to prolonged standing or prolonged sitting or being sedentary that also renders your calf muscle to have a poor function. So that also predisposes you to forming varicose veins. Smoking cigarettes, just like how it affects the other vasculature, is also a risk factor for developing varicose veins. If there's any history of trauma to the leg or infection, it also puts you at risk. Or a previous thrombosis, previous deep venous thrombosis can also put you at risk. There are hereditary factors like Kipel-Tronay syndrome, where they come with abnormal veins, abnormal capillaries, and soft tissue overgrowth that also predisposing them to form varicose veins. There are other people who have obstruction further up the venous system, especially obstruction in the iliac vein, or they get arteriovenous malformation, causing the backflow of blood, resulting in formation of varicose veins. Next slide. So what's the pathophysiology? What is going on at the valve level when you get that presentation? So you have failure of the superficial valves, which can either be can be congenital, you're just born with abnormal valves, or there could be direct injury, or superficial phlebitis when under normal pressure. So the picture there shows a normal healthy vein and a diseased vein. So during assessment, this usually look for the abnormal functioning vein, and what we are looking for is what is known as reflux. And that reflux is that backflow of blood across the valve due to the incompetence. And if that reflux is more than 0.5 milliseconds, that's considered to be venous insufficiency. And these are the valves that are affecting the greater saphenous, the lesser saphenous veins. Okay. So this is just a table depicting either a primary cause or a secondary cause of the valve insufficiency. When it's primary, it mainly affects the superficial veins, that's the greater saphenous and the lesser saphenous. The valves become stretched, atrophied, but the intima is retained, and this one really presents with more reflux. It's slowly progressive and may occur in people who have degenerative changes. While in secondary, it's usually secondary to either obstruction or reflux, and these valves tend to be scarred, destroyed from the inside, involving the intima as well. And this is due to inflammation, and this tends to be, it progresses faster. Next slide. So we've talked about the valves as a major factor for developing varicose veins. Another factor that is involved in developing varicose veins is the ambulatory venous pressure, hypertension. So you have normal ambulatory venous pressure, which is the lowest venous pressure during exercise at the site of measurement. And this is measured at the level of the hip, the knee, and the ankle. The diagram on the right just has showed the different pressures, and they are on your left side, different pressures at different levels of the body. So the normal ambulatory venous pressure is less than 30. So when you're standing, the venous pressure is usually highest at the level of your ankle. And when you exercise, this pressure drops up to 30. But in patients with venous disease, they have the inability to reduce their vein pressure, normally with the calf muscle contraction. This is because of dysfunctional valves, and thus it impairs the venous return. The higher the pressure, and you see the highest pressure is usually at the ankle, the higher the pressure, the higher the risk of ulcer formation and skin changes. Next slide. So the next slide shows different pressures at different positions. The highest pressure is usually at the ankle and is usually at 90. So the man standing, who's in the standing position, shows the pressure at 90. But when that man starts running, the pressure drops down to 30. If the man stands again, it goes up to 90. If the person is lying flat, the pressure goes down to 0. And if the person raises up their lower limbs, the pressure even goes to below 0. So the pressure is always highest when they're standing, and that explains why people who are either sedentary or whose occupation entails prolonged standing are at a high risk of getting varicose veins. Next slide. The next slide still shows the different changes in the pressure. The normal pressure curve is the one in green. When you're standing, is at 90. When you're jogging, it goes down to 30, and then when you rest again, it goes up to 90. The other colors depict different pressures, which are all elevated due to venous disease. Next slide. So what are the effects? The effects of the pressure and the valvular incompetence now leads to symptoms and that are obvious on the lower limbs. When you have a disease involving the saphenous vein reflux, it involves disease at all levels, at the level of the valves in the greater saphenous, the greater and the lesser saphenous, and also in the perforating veins. When you have painful varicose veins, most of the time is due to reflux in the greater saphenous vessels. When you have presentation of venous ulcers with skin changes, that also would suggest that there's involvement of perforators in the venous disease. So when you have incompetent perforators, which I'll go to in the next slide, it's associated with clinical worst disease. That includes the venous ulcers. But having isolated perforator disease is rare. Next slide. So what are perforating veins? So the superficial veins are connected to the deep veins by perforating veins. They are the interconnecting veins. Usually the flow is inward from the superficial system into the deep system. And the flow is usually less than 350 milliseconds. However, some perforators have inward flow despite the reflux, and they become pathological, especially when there is outward flow greater than 500 milliseconds, and that leads to venous disease. Next slide. So what is the natural progression of this disease? 25% of patients with reflux will progress within 6 months if not treated. And then if untreated, it will cause recurrence. Also, drainage elimination will cause recurrence of venous disease. And there's no known cure for chronic venous disease. Next slide. So what do we usually use for evaluation of venous disease? The first evaluation we normally carry out is take a history and a physical examination. That's the most important. Lab tests are usually not required unless you're suspecting there is formation of a thrombus in the superficial venous system. The key test that will help to make the diagnosis is a duplex ultrasonography or Doppler ultrasound, where the evaluation of the patient is performed when they're in standing position, and that way you're able to identify reflux within the venous system, that's the superficial, deep, and the perforating veins. In addition to detecting reflux, you're able to detect obstruction as well as thrombosis within those veins. For those you suspect may have arterial disease, it will also be important to do an ankle brachial reflex to find out if the arteries are also involved. Next slide. So when it comes to management, there are different categories of management of chronic venous disease. There's conservative management, there's endovenous ablation. We'll go into brief detail about that, the sclerotherapy and ambulatory phlebectomy. Next slide. So for conservative therapy, for patients with mild disease, those with the small veins and they either don't have symptoms or get symptoms, especially symptoms that are worse as the day progresses, where they are advised to have regular exercise for at least 30 minutes a day. That ensures the improvement of calf muscle pump function. In addition to exercise, they are advised to elevate their legs above the heart level to reduce swelling. That is usually done at the end of the day. For those people who are either flying who have long haul flights or have long meetings, you are advised to flex your ankles frequently while seated to ensure that to improve the calf muscle pump function. We cannot overemphasize about proper weight because obesity is a key risk factor for forming these varicose veins, and it will also propagate venous hypertension. There's a role for compression stockings. They are graduated compression stockings, which have a specific gradient that ensures that there is no edema. It alleviates the pain and improves the quality of life of some of these patients. So all these are conservative measures, especially for those with mild disease. Now for those and that's between C1 and C3. Next slide. Next slide. So for those who have advanced disease, there is the option of endovenous ablation. The slide before. Next slide. So for endovenous ablation, what endovenous ablation usually helps in, it's an invasive procedure, a minimally invasive procedure that involves either putting a catheter with a heat probe into the affected veins. Go to the previous two slides. The previous two slides. The next, before that one. So it involves putting a catheter into the affected veins, and this catheter has a heat probe that is they produce heat either through radiofrequency or laser therapy. And once they put the catheter, it's a minimally invasive procedure that can be done as a day case. Once you put the catheter into the vein, and produces the heat, the catheter is able to heat up the vessel and causes it to collapse. And thus, there's no flow in that vessel. You can go to the next slide. I'll leave it there. So I have a diagram there just trying to show about radiofrequency ablation or obliteration. There's a catheter that is introduced into the vein, and the catheter has a heat probe. When heated, the catheter causes the heat causes the vein to close. And once the vein closes, the catheter is withdrawn. And usually you'll see changes after a few weeks. Next slide. For the smaller veins, for the small to medium-sized varicose veins, those are the C1 to C2, there's a role for sclerotherapy that is involving the injection of a sclerosant, which is supposed to injure the endothelium and thus causing the veins to shrink and disappear over a period of time. Usually this is done under the guidance of ultrasound, and thereafter the patient is advised to wear stockings and continue with foot exercises and ambulation and avoid travel activity. So the other older methods that were used for treating varicose veins, that is varicose stripping and ambulatory phlebectomy, they have less role now due to the new advances in technology that make varicose vein treatment easier, faster, and recovery is also faster. I think that's the end of my presentation.
Thank you very much, Dr. Irungo Shango. That's really excellent presentation. There were a lot of questions from the ladies about varicose veins. What Dr. Shango did not say that she's actually the one carrying out these procedures, and she's the local one of the local experts in this area. And I'm sure the girls will be very happy, to know that one of them, would attend to them if the need arises. Thank you so much. That's a lot of information, and we'll be able to share it with as many girls as possible, as many ladies as possible, as many families as possible. In the interest of time, allow me to just go quickly into our next presenter. Thank you very much, Dr. Stephen Omondi, who is going to present to us about heart rhythm abnormalities, and he could touch on pacemakers if time allows. Thank you. Welcome, Dr. Omondi.
Hello. Thank you very much, Dr. BM and the entire team. I talk about heart rhythms. So my outline one, I talk about how the heart rhythm is generated, the symptoms that occur when you have abnormal heart rhythm. This will be diseases of low heart rate and those of high heart rate, and how we treat them. This is the conduction system. Think of this like the wiring in your house, the electrical wiring in your house. So we have at the top here in green, the SA node, which generates electrical current in most of us all the time. And then it travels in those yellow conductive wires, so to speak. It delays for a few seconds here in the red node called the AV node. Then it proceeds along the bundle. There's a question about the left bundle branch and the right bundle branch, which I'll see something about later. But these are the two bundles, the left, the right, and the left. So just to say one more thing about this conduction system. So this is the normal electrical current pathway, but sometimes you can have abnormal pathways, which I'll mention later. Also, sometimes you can have electrical current coming or being generated from somewhere else, either here in the atria or somewhere here in the ventricle, and I'll talk about those as well. When we talk about heart blocks, we normally mean that the conduction between the atrial part here and the ventricle is delayed. That delay normally is because there's an abnormality in this red dot here called the AV node. The symptoms that you can have when you have an abnormal heart rhythm, one, you can have palpitations. Palpitations when you are aware that your heart is beating. That could be beating fast, very fast. Sometimes the heart is beating from time to time, you get an abnormal beat that you're aware of. Another symptom is shortness of breath, which is difficulty breathing. This usually, if it's because of heart rhythm, it normally occurs at rest. So if you have got shortness of breath at rest and you're having palpitations, you can actually conclude that the heart rhythm is abnormal. Sometimes you can get dizziness when the heart rhythm is very fast or too slow. And that can result either a very fast heart rate or a very slow heart rate can cause fainting, which we call syncope as doctors. Sometimes you can get a stroke because of abnormal heart rhythm. I'll give you further details on this. This is usually from a rhythm called atrial fibrillation, and it can cause a clot form in the heart. That clot can travel to your brain, causing a stroke, or can travel to your lower limbs, the legs, or the hands, and can cause a gangrene. Sometimes when the heart is very fast, you can get chest pain, and indeed it can trigger a heart attack. But also sometimes when the heart is also very slow, you can get chest pain, even though that is rare. When somebody has an untreated fast heart rate for a very long time, they can get heart failure. And if you're very unlucky, you can present for the first time with sudden cardiac death from an abnormal heart rhythm. What can we do here in the Cardiologists and in many other centers? One, you can do an ECG. So ECG is depicted here. It's a 10-second record of your heart rhythm. If we are very lucky, we will be able to pick the abnormality in the heart rhythm. However, on this ECG here, this is a normal ECG. When we're not so lucky and we are sure there's an abnormality, we can put a Holter. A Holter is very similar to the ECG. The only difference that you wear it, as you see here, you go home with it, depending on the one we put for you. You can go home with it for 24 hours. You can go home with it for 48 hours, 2 days, or indeed for 3 days. You just keep it on for those days. It tracks your heart rhythms and keeps a record of it. When you bring back the device, we put it on a machine and we can read the heart rhythm. And if you're lucky, we can pick the abnormality if it occurred within the time that you are wearing the device. There are other wearable devices that you're aware of, the watches that people have now, that the mini watches that we have, you can use those. The other devices but within the hospital, if you can't pick the abnormality, we can sometimes put a loop recorder, which is a small device on the palm of this patient here, and we implant it on the chest, normally on the upper chest on the left side, and it's very much like the Holter I've shown you. The only difference, it can stay for many years, usually up to 5 years, and it will record every single beat of your heart. When you come to our lab, in our clinics, we have a machine to read this, and we can see what has been happening with the heart rhythm. Sometimes, as you grow older, if you present with fainting, it may be unclear whether the fainting is because of an abnormal vasculature, so the pressure drops sometimes, you get syncope from that, or from abnormal heart rhythm. And we have the facility called a tiltable lab. It's very similar to what is depicted here. We take you to the lab, we strap you to the bed, and we monitor your heart. The table is tilted. This procedure lasts about half an hour to 1 hour, and we learn quite a bit while we're doing this. I said before that the heart rhythm has a normal conduction pathway, but occasionally you get ectopic beats, and this is very common. What is depicted here, first you see a normal beat followed with a very abnormal beat, actually looking bizarre, and then you have a normal beat there. These are called PVCs. They're very frequent. When they're very frequent and we pick them up on the monitors I've mentioned before, we can treat them medically, and sometimes we can ablate them, as I'll explain later. Diseases of the low heart rate diseases. So bradycardia is what people refer as low heart rate, and that's usually a heart rate below 60. If it is below 40, it tends to be symptomatic, and you may need to have an evaluation for that. So when you come and we do an ECG and we notice this, we try and find out the cause why you're having this. It will be the medicines you're taking. Sometimes it can be low thyroid hormones, but more importantly for this talk can be a heart block, and I'll explain what that is. So I showed you before that you can always predict on this other side when the next ventricular beat will come. So this is the atrial beat, and this is the ventricular beat. Atrial beat and the ventricular beat. So sometimes you can predict that, but sometimes there is no ventricular beat following the atrial beat, and that's a heart block. There are many types of heart blocks. There's type 1, type 2, type 3, which I won't go too much detail about, but I want to show you in an extreme case, as you can see here, this patient had an atrial beat, a ventricular beat, an atrial beat, but nothing else was happening. So when this happens, you would actually faint, and a patient like this will require a pacemaker. This is actually cardiac asystole, but a complete heart block will be something like this, where the upper and the lower chambers are not coordinating. So you have a beat from the ventricle, a beat from the atrium, but they're not in coordination. And these patients also require usually a pacemaker. Diseases of the fast heart rate are called tachycardias. A fast heart rate is any heart rate above 100. Usually when it's more than 150, it can lead to fainting. So when you come, there are many causes of this, and I want to go into detail of this, but as you grow older, abnormal heart structure is a common cause from high blood pressure or from blocked coronary vessels. Indeed, high thyroid is also a common cause. And for this talk, I'll talk about the accessory pathway because that has got an obvious treatment. The disease of the fast heart rate, more common in the society is atrial fibrillation, and I'll give you a picture of this. I'll talk about other SVTs, which is supraventricular tachycardias, and then ventricular tachycardias. So you'll see from this picture, this is atrial fibrillation. So the normal heartbeat is exactly like what we're seeing up here, where you get a P wave from the atrium, and then you get a beat from the ventricle, and you can set a clock by this. But sometimes these smaller beats here are so many, and they're so unpredictable that they result in an abnormal beating of the ventricle. And as a patient, you may not feel this. You may not necessarily have palpitations from this, but in the background, because of this lack of coordination, your heart is so slow, and the atrial part can have a clot, and that clot can move to the ventricle and be pushed, as I said before, into your brain or to your legs, and you can end up with a stroke or a gangrenous leg. So this atrial fibrillation is important in the sense that it requires to be diagnosed and treated. It's common in people with high blood pressure and also common as you grow older. But occasionally you may need ablation, which is to ban the sources of this abnormal atrial beats that you can see here. And we can offer this. For SVT, so atrial fibrillation is an example of SVT. SVT just means that the abnormal heart rhythm is coming from the upper chambers of the atria. And it can be so fast, as you can see in this picture, this patient's heart rate is actually about 150 to 200. And when this happens, you can faint. And if this is happening recurrently, one, it can lead in heart failure, but two, it can make you faint, and three, actually can lead to sudden death. And we have treatment for this in the form of ablation for extreme cases, and commonly in form of medicine. The SVTs are normally from the atria, but you can also have an abnormality from the ventricle. And you will see here this nice picture that looks like a rope is when you have ventricular tachycardia. We have special pacemakers that we can use to treat this to prevent you from dying suddenly. And what we're trying to prevent is a degeneration where you go into this now abnormal pattern called ventricular fibrillation. And if you're very unlucky, there's no beat at all, and this we call asystole, and this would lead to death. All these patients depicted here, if we pick that, or we pick that, or we are very lucky we pick this, we can put a special pacemaker to try and assist you, prevent you from dying in subsequent recurrences of this abnormal heart rhythm. Getting back to the treatment of heart block, for those of you who may not know, so if you have a complete heart block, usually require a pacemaker, and I'll show what a pacemaker is. And if you have the extreme case I was showing you before, it's not a complete heart block, but that beat is prolonged, it's delayed long enough to make you faint, you'd also require a pacemaker. A pacemaker is a small device that we put on your chest. We bury it just under the chest. It has wires that go into your heart. Usually, most of them will have two wires, one in the right atrium there and one in the left ventricle. And it just monitors your heart, see if there's no beat coming through, it gives a beat of its own. It's very easy to put. You don't need to stay long in the hospital. You come in the morning, the following day you can go home. There was a question about LBB, and I showed you there were two bundles. Once the current gets into the ventricle, it tunes the device into two bundles. There's indeed a right bundle and a left bundle. The right bundle block is normally not very significant. We just observe. The commonest cause is high blood pressure. We normally just observe those patients. But a left bundle block may be significant in the setting of heart failure. Heart failure is when your heart is weak, it's not pumping normally. And if your heart is not pumping normally and you've got these abnormal wide complexes or wide beats, then you say you've got an LBB, which is a left bundle branch block. And these patients can benefit from a certain pacemaker, which I'll show you in this picture. So this pacemaker is called a CRTD or a CRTP. It's different from the one I showed before in the sense that it has got 3 wires instead of 2. So these wires, we call them leads. So there's a lead there. There's another lead going into the right ventricle, and there's a lead going to the left ventricle, but running on the surface of the heart. This again is a very useful treatment when you've got heart failure that's not responding well to treatment. And we offer this at Cardiologists all the time at a fair cost. So if this is the problem that you have, you can come, we see you, and we can recommend the treatment for it. apart from those treatment with pacemakers for slow heart rates and heart failure, we also have fast heart rhythm treatment. It can be observation, it can be medicines, but for this talk, it may also need ablation. Dr. Rungu already talked about ablation, but for us on the cardiac rhythm side, ablation means something slightly similar, but a bit different at the same time. So this is the conduction system I was showing you before. This is the normal one, but sometimes apart from the yellow ones here, there's an abnormal wire there, pathway that we call accessory pathway. When you have this accessory pathway, we can burn it. And that's called ablation. So what we do, we put many wires or catheters into the heart. We monitor what's happening in the heart, and when you find an abnormality, in the case before, that abnormality was somewhere here, so we can actually burn or ablate that, and we can cure the abnormal heart rhythm for you. I think that's the end of my presentation. Unless there are questions, thank you very much.
Thank you very much, Dr. Stephen Omodi, for that presentation on abnormalities in the heart rhythm and how they are diagnosed or how they present to the patient, as they can be major catastrophes, and also how they are diagnosed and also how they are managed. It's good just to know that all these variety of interventions are available locally here in Kenya, and Dr. Omodi is in the team that is specialized in arrhythmias or abnormal rhythms called electrophysiology, and we are happy that Kenyans can be assisted this way. I know we have really we are now coming to very close to the end of our to the end of our presentation, and because of the interest of time, I'll be very brief. And our team will continue to answer the questions on the chat and also on the Q&A. So I will just go. I'm a pediatric cardiologist, so I'll talk about heart diseases in children, and I've started. And I will be, as I say, I'll take about 7 minutes to finish, just so that we can finish, before 9. So in children, there are two types of heart problems. One is what we call congenital heart diseases, those are diseases that children are born with. And we have the second category, which is acquired heart disease, which is actually the problems that children who are born with normal hearts acquire after they have had usually streptococcal sore throat. So let me take you very briefly through congenital heart defects. And then congenital heart defects, there are two types. Classification. We are what we call pink babies and blue babies. And with the blue pink babies, what we are saying is when you look at them, there's oxygenated blood is going into the periphery up to the toes, fingers, the tongue, and you may not think there's anything wrong with the child until I come to the signs and symptoms. But in what we call blue babies, it's blue because of the deoxygenated blood going to the periphery. Much more in the people with light skins, and especially Caucasians, they will appear like blue. But in our African babies with our dark skin, it usually appear darker. The skin will be darker, the tongue will be some navy bluish, but you definitely will see that there's discoloration of the toes and the fingers and the the fingers and the tongue. Now, very quickly, which are the common conditions that children are born with? These are holes in the heart, and I'll just look at the headings and not go through the details. One is called an atrial septal defect, or ASD. These are an abnormal opening between the two chambers we call the atrium, and then I'll go and these children will present with getting tired during breastfeeding. They get tired when they're playing or eating. They have shortness of breath. They get tired easily, and you can see them sweating at rest. And when you touch their chest, you can actually feel their heart. And when it comes to growth, they are not growing well, and sometimes the pediatrician worries whether the mother is feeding the child. When we go to diagnosis, we normally use very simple diagnostic methods, a chest X-ray, which shows an enlarged heart. We do ECGs, as Dr. Modi was showing in his presentation, and there are characteristics as pediatric cardiologists will tell you this is likely to be an ASD. And when it comes to management of this, we also carry out echocardiography. Echocardiography is the gold standard, for diagnosis of atrial septal defect, and that is ultrasound of the heart. Treatment is usually some of these holes in the heart can actually close spontaneously, 20% of them, but if they are big, they will not close spontaneously. They require surgery, which can either be in the cath lab where we do interventional cath lab procedure, closing it with an umbrella, or we can go to surgery to Dr. Prem to have a surgical repair and put a patch. The next hole in the heart is between the two lower pumping chambers. Those are the ventricles. We call it a ventricular septal defect, or just simply VSD. And this abnormal opening allows oxygenated blood from the left side of the heart, to go to the right side of the heart, and causes overload in the blood supply to the lungs, and which these children also present with the difficulty in breathing, and the same symptoms as you have said with the ASD. VSDs are most commonly occurring. This is the most common occurring type of heart defect, and it accounts for 14 to 17% of babies born each year. So that's just a diagram showing where the hole between the two, between the right and the left heart, and that is where the blood flow is occurring. Again, we do chest X-ray. We also do ECG, echocardiogram. Again, is a gold standard for diagnosis of ventricular septal defect, and we are able to measure, very accurately the size of the ventricular defect as well as the position. And when it comes to managing some of these children going to heart failure, we have to give medications, and some of these VSDs, or holes in the heart, can also undergo spontaneous closure. Not all of them will require surgery. We'll have to advise, but there are some who must have surgery. And again, we have the two options of going into the cath lab and putting a device closure, or we can take the child to surgery for Dr. Prem and his team, to put a patch, in that defect and close it. Another very common problem, especially seen in premature babies, is called a PDA, and this is failure of closure of adductus arteriosus, and this is one of the simplest problems to take care of. However, it's missed a lot of times, leading to unnecessary complication in children. So children need to be examined, and especially when they are prem, but not, and even full-term babies require our diagnostic to be reviewed if they have symptoms that are, of shortness of breath, congested breathing, disinterest in feeding, poor weight gain, sweating, tachycardia, and when you feel their pulses, they are very, very, they are bowdy. Now, those are the three pink lesions, as we call them: ASD, VSD, and PDA. Let me just run you through two of the blue babies, which is the commonest of the blue babies, is tetralogy of Fallot. It's a long name, but it just means that there are four problems: that there is a hole in the heart, there's a narrowing of the blood vessel, the aorta is bigger than normal, and the right side of the heart is enlarged. Management here almost all the time requires surgery, either early as 6 months to 18 months, but even when we catch them later, we are able to close the VSD and enlarge that blood vessel that is narrow. There's also another very serious heart problem called transposition of the great vessels. It means that the artery arises from the right ventricle, and that is the aorta that we just talked about earlier. And the pulmonary artery, which should come from the right ventricle, comes from the left ventricle. And usually these are blue baby, this will present as is the second, comes second to the one we said TOF, and these babies end up, so that is what we are seeing, something that is abnormal. You may not be able to recognize what is abnormal is that the aorta is coming out from the right ventricle, whereas the pulmonary arteries, we should be coming from this side, actually coming from this side. This bluish discoloration that we see and rapid and labored breathing, cold, clammy skin, and failure to thrive require that these babies sometimes require some interventions as soon as they are born, and we normally would admit them into a neonatal intensive care unit, put them on a ventilator, and open up that atrium to allow blood oxygenated blood to get to the left side. I will not go into more details, except to say there's a lot we can talk about congenital heart disease in children, but thank you for listening to that. I'll give you just 3 more slides on acquired heart diseases in children. And these acquired heart diseases in children are usually in our environment, and even rheumatic heart disease. Rheumatic heart disease is I need to do. Rheumatic heart disease is a chronic condition resulting from rheumatic fever, which is characterized by scarring and deformity of the heart valves. And the commonest valves that are affected are the mitral and the aortic in that order. But however, all 4 valves can be affected. It's principally a disease of childhood with a median age of 10 years, although it occurs in adults in 20%. Rheumatic fever occurs in equal numbers in males and females. Somebody had asked about that, but the prognosis is worse for females than for males. And the disease is more commonly in poor socioeconomic